And now a few words about today's distinguished presenter, Dr. Uruj Haider. She is the Medical Director of Consultative Services at MCPAP for Moms. She is also Medical Director of Women's Mental Health Clinical Services at the UMass Chan Medical School and UMass Memorial Health. She is Assistant Professor in the Departments of Psychiatry and Obstetrics and Gynecology at UMass Chan Medical School and UMass Memorial Health. She's a consulting psychiatrist for the Lifeline for Moms Network in helping develop perinatal psychiatry access programs. Dr. Haider is also the lead perinatal psychiatrist in the Community for Women's Care Clinic, the Women's Mental Health Clinic, and the Reproductive Endocrinology and Infertility Clinics at UMass. Dr. Haider has special interests in OCD, sleep, and postpartum psychosis, and she enjoys collaborating with families and navigating the postpartum phase. And now I will turn it over to Dr. Haider.
Hi, everyone. I'm looking forward to being here. Just a little bit of a delay while we get the slides up, as often happens in Zoom world. So Beth, I'll give you a second to go through that.
Uruj, can you send those slides again? Okay, thank you.
Yeah, unfortunately, we're having a little bit of a problem. And Parvina and Beth, if you could just give moderating privileges to Nancy. She can't turn on her video or microphone, just an FYI when you get a second. Thank you.
Yeah, she's in.
She just can't turn on her video or mute. Just bear with us, just 1 or 2 more minutes, hopefully. Really sorry about the delay. We'll figure this out. All right. Beth, do you have them?
We still don't have the attachment.
All right, give us a sec, guys. Sorry about that.
The text message doesn't work.
Your email, Parvina, and yours email.
Uruj, yeah, I don't see the attachment on the email. Sorry.
All righty, let's get started. Can everyone see this? Show of hand. Nancy, can you see this? Amy, can you see this?
Yes, I
we
can
can
see
see
it. We're all
Yep.
set.
We can
Just kind of and
Yep,
get
we're good.
started. We'll pick that out. Sorry about the delay. All right. So I am looking forward to being here today to talk about Zuranolone and MCPAP for Mom's role in Zuranolone and how to prescribe this medication. And next slide, please, whenever you get a moment. I have no financial disclosures to report. I have no affiliations with Sage or Biogen. Next slide, please. So the objectives for today will be to discuss Zuranolone prescribing guidelines. We'll go into MCPAP for Mom's role and how exactly we can help. Next slide, please. All right, so neurosteroids and postpartum depression. So I'd like to introduce this theory about neurosteroids and postpartum depression and how exactly Zuranolone came to be. So the exact pathophysiology behind postpartum depression has been unclear, but what we know is that it's associated with a rapid decline postpartum in progesterone and neurosteroid hormones, and a lot of complex changes in many different neurotransmitters. And the main pathology behind postpartum depression is that we have this postpartum reduction of neurosteroids referred to as this neurosteroid withdrawal. So hence the idea of inserting neurosteroid replacement theory or Zuranolone or Brexanolone has become kind of a novel approach of approaching the treatment of postpartum depression and other conditions related to neurosteroid deficiency. And so the main concept I'd like to introduce with you all today is that here in postpartum depression, there exists this very delayed therapeutic benefit of SSRI treatment, which could potentially put the mom and the infant at some risk depending on the severity of illness. So there's this compelling medical need for targeted postpartum depression drugs to provide this rapid relief of depressive symptoms. Next slide, please. So in this picture, I like this picture because it really just shows the biosynthesis of the neurosteroid allopregnanolone or Brexanolone, Zuranolone, synthetic versions of allopregnanolone in the brain. So the two FDA medications are these two. They're neuroactive steroids, NAS we refer to. And what those are is they're really metabolites of pregnenolone. So it starts with cholesterol we see here on the left, and then it goes to progesterone and then to allopregnanolone. And it's that metabolite that interacts with the GABA-A receptor in the brain. So there are 20 to 30 different subtypes of GABA-A. Some bind benzo, some bind barbs, and NAS are very specific to only a few of these GABA-A receptor subtypes. So because these steroids are working on GABA, which is really the main neuron inhibitory chemical in the brain, which also balances the excitatory effects of glutamate. It's this back and forth excitation inhibition dance in the brain that's the premise of this working theory. And there's also evidence that long-term stress and trauma can really impair these neuroactive steroids from keeping this balance or this back and forth dance in the brain from occurring, especially when neuroactive steroids change rapidly in pregnancy and in the postpartum period. Next slide, please. So, Brexanolone, Zuranolone is this, I'm sorry, Beth, can you go to the next slide, actually? And the slide after that. Okay, so the neurophysiology of kind of all of this and how this really applies to Zuranolone and Brexanolone. So the GABA-A receptor has 5 subunits that we see here in the center, and that's around a transmembrane ionic channel. So when you bind in certain areas, particularly around synaptic clefts, like benzodiazepines, GABA, this really leads to rapid but delayed phasic effects. And I think that's a key clinical point, because when we give someone a benzodiazepine, Xanax, Ativan, it opens that channel, but it really only stays open for a brief period of time. And I think this has a lot of clinical application because it's something that we use to treat anxiety quickly, but it's not going to have that long classic effect or impact on depression really. So hence Zuranolone. And so on this slide, we see the presynaptic terminal. We see on the purple is the synaptic GABA-A receptors on the synapse, and the extrasynaptic GABA-A receptors are on the green on the right. So synaptic on the left, green GABA-A, extrasynaptic on the right. And it's these extrasynaptic receptors that are really not at the synapse, and they're generally around the membrane in the transmembrane ionic channel. And it's that side where positive allosteric modulators bind, like allopregnenolone. We abbreviate them as PAMs. And this is how we know that brexanolone, zuranolone, it leads to a rapid and sustained or tonic effect. And that's what we're clinically striving for. And that's what these trials were clinically striving for and we're able to accomplish. So that way we can get that rapid impact on a female's system, but we can also hope to see it sustain. And the duration of the treatment is very brief. So like 14 days. Next slide, please. And so this slide really just explains the relationship between the GABAergic system in our brain and allopregnenolone and progesterone levels and how the two are related. And so we can see here some nice clinical applications. So what we know is that progesterone goes up in pregnancy up until birth. Allopregnenolone goes up with it. Allopregnenolone in the red, progesterone in the blue. You can't really see here that the allopregnenolone actually falls a little bit before the progesterone, but in pre-pregnancy, at the bottom here, you have our GABAergic receptors. So GABA is being released. And we only have a certain amount. And in the first trimester in pregnancy, the levels go up, but it doesn't necessarily absorb all the receptors. It really just upregulates or downregulates part of the receptor to make it more or less sensitive to the GABAergic property. So in the postpartum period, which is key here, everything drops. These levels drop, and our body naturally is supposed to readapt and really adjust or upregulate, modify these GABA-A subunits on these receptors, which allows for allopregnenolone to have the effect it does. And so that's where the theory of zuranolone and like decades of this, this research, that's where they both are kind of, they become married and merge into each other. So a theory then emerged that maybe in postpartum depression, it's really a receptor plasticity issue, which is interesting. And so in previous studies, they found that mice that didn't have the GABA-A receptor subunit, they noticed how lethargic and how little they moved, and that they quantified or qualified as depression. So applying that concept here, maybe our patients with postpartum depression, maybe they have a genetic predisposition where they're not upregulating something in their system, is really not adapting. So when these levels fall in the postpartum, they don't self-regulate, adapt, and they fall into this depression. And that's how synthetic versions of allopregnenolone and like zuranolone and brexanolone were created. Next slide, please. So what is zuranolone? It's the first FDA-approved oral medication for the treatment of postpartum depression. It's a once-daily oral 14-day medicine. It's a neuroactive steroid GABA-A receptor positive allosteric modulator, as we briefly discussed. Zuranolone is a synthetic form of allopregnenolone. Next slide, please. So the Robin and Skylark studies, what I liked is they really mirrored the brexanolone studies, and they were pretty clinically applicable to a lot of the patients that you and I are seeing in our perinatal mental health clinics or our obstetric clinics. It is a hormonal triggered clinical depression. In these studies, there was no data for bipolar affective disorder with psychosis, active substance use. It's really only that unipolar depression with peripartum onset. And again, good clinical application. These patients had trauma, they had ACEs, they had anxiety and trauma disorders. So I think that was very important to, for them to be cognizant of. Next slide, please. So how does it work? So there are 2 phase 3 clinical trials, part of the NEST neurodevelopment program. We like birds here. So what this showed was rapidly improved symptoms of postpartum depression at day 15, early as day 3 with sustained effect to 45. Short treatment course, but found to be effective. They work fast. As early as day 3, some of these patients were seeing effects and feeling better, and with sustained effect. So, back to that early slide where we're really targeting the specific receptors that work fast, but with sustained effect. The most common side effects, greater than at least 5% with zuranolone, were somnolence, dizziness, diarrhea, fatigue, UTI, no loss of consciousness or suicidality. That was assessed with a CCRS. Next slide, please. So the effect of zuranolone versus placebo in postpartum depression and RCT, this was the first of the 2, the Robin study. And so this was a phase 3 double-blind randomized outpatient placebo-controlled trial. And so for both these studies, these were women aged 18 to 45, less than 6 months postpartum, with postpartum depression, onset of a major episode in third trimester or less than 4 weeks postpartum, randomized 1-to-1 to placebo to Zuranolone, 30 milligrams in the evening for about 14 days. Baseline HAM-D score of at least 26 was used. Next slide, please. And so this study really summarized the robust results of this study. So what they did, you can see here on the y-axis was the HAM-D change from baseline CFB and least square mean change, and on the x-axis at the time. So they looked at change from baseline and HAM-D 17 total scores. Zuranolone in the Robin trial was given at 30 versus the placebo once daily in the evening for 14 days. 76 ended up taking the Zuranolone, 74 patients ended up taking the placebo, both similar demographics and baseline characteristics. About 20% in both groups were on a baseline antidepressant, actually, that they had been on that before. Obviously, it wasn't working as well, but they were continued on that throughout the treatment and out to, we can see here, the day 45 mark. And out to follow up at day 15, and then they were follow up until day 45. So they're taking the oral Zuranolone once daily in the evenings, and the following day, day 15, they were assessed, and that was the primary endpoint. So the other endpoints, 3, 8, and 15, and 45, were actually all statistically significant. The results are summarized on the left. And they were all statistically significant in terms of separating from placebo. So you can see at day 15 here in the blue box in the center of the graph, you have that drop with Zuranolone and HAM-D, and that was nearly 18 and over 14 for the placebo, statistically significant. And so at 15 days, the response rate, the response was defined as greater than 50% reduction from baseline, and remission was defined as a HAM-D score of less than 7. The response and remissions rates was 72% and 48% for placebo, and that was the response, and the remission rate was 45% versus 23%. So this is robust and clinically significant. Next slide, please. And so Zuranolone for the treatment of postpartum depression was the Skylark study was the second study, and this is really a replication of Robin, but at 50 milligrams. And this was a phase 3 double-blind randomized placebo-controlled trial. Women with severe postpartum depression randomized 1-to-1 placebo to Zuranolone or placebo for 14 days. Similar demographics as the last. Next slide, please. So again, very similar inclusion, and inclusion criteria. And so Skylark had similar results to the Robin study. And so the way that the Skylark study, I think, was interesting in that it was statistically set up that they were able to not only look at the primary endpoint at day 15 here, but they also looked at statistically at day 3 and as a key secondary endpoint, and they also saw significant differences there. And the women had statistically significant differences at the primary endpoint at day 15. And statistically significant differences at days 3, 28, and 45 summarized on the left hand of the slide. So these are frequent measures than having the evaluations at 3, 8, and 15 as in prior. And potentially, I think, is being able to simulate a placebo response. And you can see that it's still separated here on the chart on the right, on the graph on the right. So the response was rapid. It was sustained to day 45. We see that x-axis go all the way to the right, and it was significant and statistically significant improvements were seen at every time point. Next slide, please. So the conclusions from the NEST trials, what I would say is that, Zuranolone really improved the core symptoms of depression as measured by HAM-D scores in patients with postpartum depression and was really well tolerated. So there was clear evidence in supporting the potential of Zuranolone as a novel, rapid acting oral treatment for postpartum depression. I think that along with brexanolone, this is now the second of its kind, and so it's robust evidence, and it was statistically significant. The main limitations I saw in these studies was, they're not globally generalizable. These were studies done in the United States, so I would like to see them in geographic regions, across the world. So I think that has yet to be determine, and sustainability of treatment response beyond day 45 is unclear. I see a few questions rolling in. I think what I'll do, like I did for the postpartum psychosis webinar, please keep them coming. And at the end, I'll answer all those questions. A lot of them relate to some of the later slides I have, so please keep them coming. And I look forward to answering them at the end of the presentation. So the sustainability of treatment response beyond day 45 is unclear. I certainly want to see, while the results of this study were significant, I would really like to see what happens beyond that day 45, that 45-day mark, 3 months, 6 months out. How sustainable is this treatment? So this study really ended at that mark, so I think future studies will probably look into that. And the safety and breastfeeding needs to continue to be evaluated, and I have a few slides on that later. Next slide, please. So how do I prescribe Zuranolone? This is the stuff that I love the most, the prescription part. So it's FDA approved for monotherapy for 14 days daily. It was timed to be in the evening because of possible somnolence, and so it's really patients. The idea was patients have their meal and they take it after a meal and then they go to bed. So that's the evidence-based FDA recommended treatment course. If there's hepatic or renal impairment or use of other sedating medications, drug-drug interactions is key, then you want to consider the 30 to 40 milligrams daily. But I think the FDA recommends really starting at 50, and if there's clinical indication to decrease to the 30 or 40, then you can do so. The tapering is not actually studied and not necessary. So there are no withdrawal symptoms in the Skylark trial that we saw. So that was studied and accounted for. So you don't need to taper. You take it, 14 days, same dose, and you stop. If a patient is on an antidepressant already, you want to continue that antidepressant and then prescribe that Zuranolone. That's kind of the working idea in terms of how it works. Prescribing antidepressants after Zuranolone treatment really should be done on a case-by-case basis, and it clinically depends on the patient and that patient's history and symptomatology. In terms of when if a patient were to present to me in my clinic a couple of months postpartum, a clinical assessment in terms of when the patient started feeling unwell, I think is warranted, because that can really help you discern the timeline and kind of when all this started. And then that can help you decide if this patient is an appropriate candidate for Zuranolone. And that's what the insurers are actually looking at for coverage too, because that's how the trial was designed. And so that makes sense. So I ask my patients, do you remember when you started to feel differently or unwell? You want to follow the evidence-based guidelines for perinatal onset. That would be my biggest rec. Next slide, please. So dosing. So dose adjustments are necessary if patients are taking meds that are strong CYP3 or A or 4 inhibitors, so clarithromycin, erythromycin, diltiazem, itraconazole, ketoconazole, ritonavir, golden seal, grapefruit. Concomitant use with a CYP3A4 inducer should be avoided. Phenobarbs, phenytoin, rifampin, St. John's wort, glukes, the 3A4 inducers that most of us are familiar with. Next slide, please. So Zuranolone and fatty foods. So to really maximize the benefits of the medication, you want to consume it with a fatty snack, preferably at night. So you want to discuss that overall caloric intake and a high fat diet, especially if breastfeeding. And I know there are a lot of questions about how much fatty food do I take it with, if at all? And it's really not, it doesn't have to be a huge fatty meal or like a big cheeseburger. I mean, it certainly can be, but it doesn't have to be. So the FDA recs are take it with 25 to 50% fat and a 400 to 1,000 calorie meal. And so when I actually went and, looked at the macros, what this is equivalent to in a 1,500 calorie diet, that's about equivalent to 50 grams of fat daily. And that's on the generous side, I would say. That's equivalent to about a few tablespoons of peanut butter, maybe an avocado, eggs, whole milk yogurt. So I think just keeping that in mind, you certainly don't have to change a patient's diet or regimen to consolidate the fattiest foods at the end of the day. It's really a high calorie snack. Most average diets in America have enough fat in them. So it's just reminding the patient you want to take it with a fatty snack and at night, because that's the best for absorption. That's what, what was decided by the people who designed these trials in the FDA. Next slide, please. Zuranolone and SUD, substance use disorder. So in general, I would start at 50 milligrams unless there are other CNS depressant medications. And then you want to consider decreasing to 40 milligrams or 30 milligrams daily. So it's really less of a drug-drug interaction concern, and it's more a concern with oversedation. So somnolence was a big side effect in these trials, and somnolence was reported by these patients. So I think that's the key thing here. There was no loss of consciousness in the clinical trials to date like there was with brexanolone. So it was fairly well tolerated, so that's great. So, but we do need to keep an eye on the somnolence in terms of what other medications are the patients on that may make them feel sedated or somnolent or really fatigued. So, for example, alcohol use. Besides psychoeducation, you want to consider a reduction in dosage. You want to monitor that somnolence closely if the patient is disclosing that to you and being forthcoming about that. Without shaming, let's talk about it. There's a short-term course pill. We really want to reduce any potential for cognitive impairment. So that, I would say, for example, would be an indication on a case-by-case scenario to look at if the dose should be decreased to 40 or 30 or started at a lower dose, as was done in the Robin study. So legalized substances, no data, for example, on marijuana. If we're asking ourselves about absolute contraindications, the data for marijuana was just not done. The patients were drug tested, and that's really, the data is not there, because the patients were drug tested for these substances. So it's very patient specific. And I ask my patients, are there any other substances that you're using or taking any medications that are CNS depressants? It's really that additive CNS depressant effect with that whole picture with Zuranolone and anything else they're taking. Intentional overdose of Zuranolone. So there's no actual antidote created that I know of. I'm pretty sure there is not, but I would say you really, again, want to closely and cautiously monitor that somnolence. That's the biggest side effect. And of course, all safety techniques. Next slide, please. So Zuranolone, other precautionary measures. So the FDA recommends that patients of reproductive potential use effective contraception for a 14-day treatment period and 1 additional week. If a patient misses a dose, you don't double the dose. You just resume it the next day. So if a patient tells you, I forgot my dose yesterday, tell them to take the dose that they're due for today in the evening, and then the dose the next day after, no doubling. You shouldn't drive or engage in hazardous activities due to potential CNS depressant effects, as we discussed. So this is all on the label for Zuranolone. You shouldn't operate machinery for at least 12 hours. No evidence for mild illness. This is really moderate to severe depression. Not FDA approved for major depressive disorder. I would recommend, really following the evidence-based guidelines for perinatal onset. Next slide, please. So Zuranolone and lactation. So this is from unpublished data from a poster presentation done by the PI of these studies, Christina Deligianides. And it's not published or released, but I really just summarizes that and put it on this slide. So this is not my own, but it's a summary of what is out there right now. And what it says is the amount of Zuranolone found in breast milk following daily administration of Zuranolone 30 milligrams over 5 days was low compared with the maternal dose. So the estimated mean relative infant dose was 0.3%. That's low, and that's lower than most antidepressant SSRIs, I have to say. And the daily infant dose was 0.0124 mg per kg per day on day 5. So these, I think the take-home point is these are low numbers. It wasn't obviously a big, control trial. It can't be, but from the sparse data we have, it's reassuring. The estimated mean RID was consistent with a low fraction of unbound Zuranolone in the plasma. So Zuranolone was 30 milligrams, was generally well tolerated when administered to healthy lactating participants for 5 days. Next slide, please. And so the study limitations also from the same poster presentation. So limited generalizability, the sample size was small, therefore the effect of Zuranolone on milk production was based on the sample size. It may not be generalizable to broader populations. Variability of milk production at baseline. So the interpretation of the effect of Zuranolone on milk production is really limited due to the variability in interpatient milk production at baseline. There was no comparator arm, no placebo arm, so limited interpretation. And I think key thing here, this study, according to this author, was not designed to assess safety in infants. The infants were not intended to receive the drug. Therefore, the safety of Zuranolone in infants could not and was not evaluated during this study. Next slide, please. So let's get into the access, because I know this has certainly been a big question and a concern about this medication naturally. So this is from the policy report from Joy Burkhardt on her website, 23moms.org. It's accessible on her website. So this is the most recent data that I think that's out there in insurance companies. It was published just on December 15th. So the 6 largest U.S. insurance companies coverage policies, not all of them have defined coverage policies. The only one that really has been released is Centene Corporation. And just as a reminder, the lack of a released or published coverage policy does not mean that they're not going to cover or insure the medication. It just means, what I take from it is that they're still figuring things out. And as more people prescribe the medication, the more answers there will be. Next slide, please. So the insurance, and this chart really details coverage policies and restrictions. And this is what I see to be a potential barrier when it comes to prescribing. This is again for a few states across the nation. But it's not all inclusive, and I think this is still being updated. But one of the few 18 insurers included in this report, with one PBM, included coverage policies, but limited it in the sense that 5 required patients to try another antidepressant or another drug first and to fail that. So that's really where we're introducing step therapy, or like a failed first step up, which can be limiting for many, many patients. And 3 insurers said that they wouldn't cover Zuranolone if an OB or a non-psychiatrist prescribed the drug. They can prescribe the medication, but the coverage became very, very unclear there. So I think that potentially could be a big limiting factor. So I think that's also an opportunity, if that were to happen theoretically, in Massachusetts, for MCPAP for moms to help and really help with that consultation and evaluation, and we could see the patient, and then that report could be sent directly to the insurers, because we're really trying to just reduce barriers here. So this, the drug is specific to the treatment of postpartum depression, which I think OBs and so many different healthcare providers are qualified to treat. So I really think that insurance companies, I hope that they aim to reduce these barriers, and not allowing coverage for certain providers, can be a significantly big barrier as well. Next slide, please. So specialty pharmacies. So Zuranolone is being prescribed from a specialty pharmacy. What is a specialty pharmacy? So I think understanding that may understand why it's been a challenge to prescribe for some patients, at least initially. Specialty pharmacies are not retail pharmacies. There's no physical blueprint out there. So I think also sharing that with patients is important, so they don't go to their local Walgreens and be like, do you have my Zuranolone prescription? It's going to be mailed to them. And the reason is because specialty pharmacies provide medications to generally treat rare or complex health problems. So they are used to handling, high-priced drugs, infusible drugs, special handling, administration. Sometimes drugs have to be transported with a very specific temperature or handling requirements, and scheduled products. This is a C4 product, and so this is going to go through the specialty pharmacy. It's a federally controlled substance. So generally they offer clinical services above what retail pharmacies can provide. It is not a retail pharmacy. It's not a footprint. It is mailed to the patients, and also telling patients that, I think, is critical. Next slide, please. So far what I have seen is that payers are interested, but there's heterogeneity in approval. So coverage policies and prior authorization policies are still being worked out. The drug is relatively new, it's been out for a little bit, but people, I think, are now understandably really want to prescribe it and be like, well, if it works fast, let's see what's going to happen. And so we're seeing that that insurers are also figuring it out, but it's getting prescribed from what I've heard so far for the most part. I'm sure there are certainly exceptions. Prior authorizations are varying per insurer and per plan. So I think being aware that a patient who may have, a specific plan through Mass Health or Blue Cross Blue Shield, it's not going to be the same for anyone with Mass Health or Blue Cross Blue Shield. It really varies per employer. And so we're learning about the coverage through these prior authorization requests. Are there limitations for the plan? So there's no specific FDA-approved medication other than Zuranolone for patients with postpartum depression. So I would really hope that the insurers are also saying we're aiming for fair and equitable access. There's really nothing else out there like this, and it's oral. It's not Zuranolone. It is not IV. They can take it in the comfort of their home. So let's think about that, and I hope that things continue to improve and get better. There is some legwork engaging the insurance company and specialty pharmacy in this process, which I'll get into the next slide because I think that's critical to having this be an easy process for our patients. Next slide, please. Okay, so in my discussions with Sage and Biogen representatives when I was prescribing for this for my patients, they were very helpful. And what they strongly encourage is a few things in this. I wrote out this step-by-step plan and how to get the medication hopefully fully reimbursed for our patients. But the first thing they actually recommend was that clinicians should first run a benefits investigation. And what this means, and Sage and Biogen can assist with that. The phone number for that is at the bottom. That's the 844 number, the Zurzuve for you, healthcare providers and patients can call. So what this means is first, the clinician or the patient should call the patient's insurance company and find out the patient's specialty pharmacy. This is key. Finding the patient's specialty pharmacy first is going to make the process so much smoother. And I'm also seeing that for a few of my patients. It's certainly expediting it. There are 5 specialty pharmacies right now. There were 3, now there are 5. The phone numbers are on the next page, on the next slide. I'll get to that in a sec. But we want to specify that the name of the specialty pharmacy first by calling the patient's insurance company. The clinicians should call the patient's insurance company, inquire about appropriate documentation, prior authorization, etc., and complete the paperwork. And then submit this and send the Zuranolone prescription to that specialty pharmacy in the patient's EMR. It's going to be a very specific address, name, obviously. So clarifying that first, I think, is important. Clinicians should alert the patient that they will be receiving a phone call from the specialty pharmacy trying to process the benefits investigation with their clinician and to confirm patient's address for shipping medication. Number 3 is really important. The Biogen representative I spoke with emphasized that, and in my own experiences with my patients, I think it's important because sometimes it comes from a mass number, and patients, if it's mass or if it's hidden or if it's private, some patients may not pick it up, and that can certainly delay the process. So just let the patient know a specialty pharmacy from an unknown number is going to be calling you within the next 20 to 48 hours, 3 to 5 business days. So just please be aware and have your phone near you. Specialty pharmacy will then call the payer and finalize documentation, prior authorization process, etc. And so they're going to address that with the insurer. This is probably the most anxiety-provoking part of all of this. But once that payer finalization is complete, and hopefully it's fully complete, the medication is shipped from the specialty pharmacy directly to the patient's home. And MCPAP for Moms can help at any point during this process, and I'll get into a little bit about how exactly we can help because it's new and it can be initially overwhelming, and we're happy to be here and make it easier for you all throughout these steps. Next slide, please. So there are 5 specialty pharmacies. Feel free to take a picture of the slide. So CVS, Caremark, Walmart, Accredo, Alto, and there's a specialty care pharmacy for Puerto Rico only. I could not retrieve that number, and when I do, I will update that. Healthcare providers, ZurzuvaHCP.com, consumers, and everyone, Zurzuva.com. Again, this is the patient support program, 844-987-9882. They're open Monday through Friday, 8 to 6 EST. And again, clinicians should really run that benefit investigations first, as I had mentioned on the earlier slide. Next slide, please. So Mass Health and Zuranolone. I think this is important. The current advice from Mass Health is as such. Zuranolone is currently under review and is scheduled to be added to the Mass Health drug list on March 4th, 2024, and will require prior authorization. And while under review, it'll be reviewed for PAs for medical necessity and approving when criteria is met. So the prior authorization criteria for Mass Health and Zuranolone prescribing includes a specialist provider, OB-GYN, family medicine, psychiatrist, or having consult notes from a specialist. And this is where MCPAP for Moms, again, can help with the face-to-faces and evaluating the patients in a clinical assessment. The member has to be less than or equal 12 months postpartum and not currently pregnant. This follows the guidelines of the FDA recs of who's eligible for the medication. So that shouldn't be too hard. They are requiring an inadequate response to defined as at least 4 weeks of therapy or adverse reaction to one antidepressant, citalopram, bupropion, duloxetine, SSRIs, SNRIs. So I think that last part is key. Mass Health is saying that the patient has to have an inadequate response, fail an antidepressant, or an adverse reaction to one of the antidepressants before considering, the reimbursement for this. Next slide, please. So costs, other limitations. So the actual cost for Zuranolone is actually $16,000 for a 14-day course. That is costly. So we certainly hope that it gets fully covered, and we're hearing that it has been for many colleagues. And so what happens after that 45-day mark? I think that that's also a potential limitation. It's great that we have a medication that works at 3 days, but if it really takes up to 3 to 6 months at times for our patients to find psychiatric prescribers or even get an appointment with a psychiatrist, especially those who have Mass Health, and that is going to be a limiting factor. And MCPAP for Moms can help in that timeline, but that's just one potential limitation I have being a concern. And also, Sage Therapeutics designs Zuranolone to be like an episodic treatment, almost like an antibiotic regimen, like you take it for 2 weeks and then you stop. So that means patients will take the medication for 2 weeks and stop, but it's unclear, as I had mentioned earlier, what really happens after that 45-day mark, and because that's what was investigated in the clinical trial. So if patient symptoms recur, I think follow-up studies are going to be quite necessary to find out if they can, safely or effectively be treated with a second dose of Zuranolone. I know that's a thought, but has not been looked into yet. And does the improvement in symptoms mean that they're good for life? With antidepressants, I prescribe it, I follow them up every 1 to 2 to 3, 4 weeks, and I titrate up as clinically indicated. I have the time to do that and create that schedule. So with Zuranolone, what are we going to do long term? What happens after that? Next slide, please. How can MCPAP for Moms help? So the patients that are referred to me in my women's mental health clinic, I would say they are likely to have more severity and have more unclarity on diagnostic clarification in terms of illness severity. And so I think that's for patients, for other providers who have similar patients, that's a big opportunity for MCPAP for Moms. And we can really help facilitate and help discern specific clinical criteria and symptomatology to see who's really the best eligible or would benefit the most from this medication. And we can do that through a phone consultation and or a face-to-face. So we can help providers really evaluate perinatal psychiatric history, comorbidities, other medications they're on that could be potentially sedating. If a patient is still on a pain medication from delivery and they're not sure if it's making them tired, if they're on a benzodiazepine, do I start the Zuranolone, do I not, but they qualify, we can certainly help with all of that. Suicidal attempts, previous psychiatric hospitalizations. There are so many different clinical features that I think play into when do I prescribe it? Do I prescribe it for this patient? And we can certainly be there and help through all of that. And so in summary, I would say, it's a great pill that can help with postpartum depression symptoms early. It's not a panacea, I think, for a major problem that we have that affects so many women worldwide. And we still have a toolbox of options at MCPAP for Moms that we can offer you all in addition to Zuranolone. So this is really one more tool in that toolbox. That's kind of how I like to frame it, to calling providers. And I would say it would be helpful I think it's important for providers across the state to know that we have so many established options like SSRIs, individual therapy, support groups, resource and referral. If like I had mentioned, is an insurer requiring a consultation with a psychiatrist, so we can help with that. If a patient requires side effects of the medication or doesn't benefit from the medication at all, we can certainly help with that. Any questions about the prescribing or titration process, patient eligibility, MCPAP for Moms can help with any of those. Next slide, please. I'll just look at the time. So MCPAP for Moms collaboration. So we notice an improvement as early as 3 days. Can a social worker check in with your patient around that time? And we're always happy to do a doc-to-doc and go through the specific questions that may be asked during this time. Do you want to consider contacting MCPAP for Moms at any point during the 2-week period or after? We can certainly collaborate and help with any clinical questions that come up during that period, do a phone consultation or a face-to-face if clinically indicated. We can help with connection to care in the community, psychotherapy, peer support, dyadic intervention, psychiatric prescriber at any point during this prescription phase or after, or come up with a plan on how often to check in. We're happy to discuss all of that. Next slide, please. So in summary, we are here to help and really to help continue to build your capacity as we've really enjoyed doing over the last decade. Next slide, please. And so through trainings and toolkits, real-time provider-to-provider, phone consultation, linkage with community-based resources, we are certainly here to help you with all that. So I am just mindful of the time. So let me just go ahead and bring up the chat. This concludes my slides. I just want to make sure I see a few questions coming in. Why was there a big placebo effect? Good question. There was a big placebo effect. I think it was consistent, I will say, with the effect that we've seen in antidepressant trials for major depression disorder for both men and women in the past. And it actually wasn't too different from those when you actually look at the studies. So I thought that was good. But in previous antidepressant trial, the primary outcomes were actually much farther from that 15-day mark. They were like 4 to 6 to 8 weeks out. So I think, and there was no real follow-up in between. And then the visits really spanned, over a couple of months. So I think that's what's interesting about these NRT trials. There's a lot more follow-up and a more condensed period of time. And I would say, going to your question, was there a big placebo effect? So these patients were at home. This was outpatient. Zuranolone is administered these patients take it in the comfort of their home. They have their structure in place. They have their family support systems in place. So that's a really big thing where they have a lot of their support systems in place. And that certainly, I think, could be a reason for the placebo. That whole structure is already in place. And, if they have toddlers at home, they have that support too. So I think that's probably a big reason. It's FDA approved for 50 milligrams daily, but it was tested at 30 milligrams. So when would you start at less, and when exactly would you consider adding on an antidepressant? So yes, so for Robin, it was tested at 50 and it's FDA approved for 50 milligrams. And so I think the reason, I don't know actually why it was like 30 and 50. I think that it's probably because the FDA likes to generally have a range to prescribe medications. And as we saw, if there's like an adverse side effect, or somnolence or whatnot, you have the ability to kind of tweak that dose depending on what other medications or clinical indications to go down below that 50. So they probably just wanted a working range to start with. So I think that makes sense. The FDA recommends starting at 50 milligrams, monotherapy, short treatment course at 14 days, and you can certainly reduce to 40 depending on factors that we had discussed. But the majority of the patients, according to the Robin and Skylark studies did fine at 50 milligrams. And I think the only exception would be is if CNS depressant medications were added on or whatnot. So, you know, it's best to be used as monotherapy. And if no treatment response by day 15, when would you exactly consider adding on an antidepressant? Then you can consider another antidepressant at that point. And I would say I would not personally start Zuranolone antidepressant at the same time, looking at the study design, but also I don't do that because then you don't know what's working. If there's a side effect, if there's like extreme somnolence or, you know, uncomfortable GI distress or side effects, you're not going to know which medication is actually responsible for that. Was it the Zuranolone or was it the SSRI? So that's what I would say. The only exception I would say is probably a benzodiazepine with an antidepressant. I think those two it's clinically indicated that you sometimes have to start them at the same time. But Zuranolone and SSRI, I would not. I would probably wait till after that 50 milligrams dose. And I would emphasize the importance of checking in with them. You know, it's not like well, here's 2 weeks, see ya. You know, it's let's bring them back in. Let's call MCPAP for moms. What questions do I ask? How can I help them further? And see if there's clinical indication to add something else after doing a check-in, doing an EPDS, you know, and whatnot. So yeah, that's probably what I would say to that. And yeah, so could MCPAP for moms help decide which parents to give it to or how to have a discussion in breastfeeding? Yes, definitely. So from the data that was shown for those specific number of dyads, I think it was 12, it goes through the breast milk. It's not a monolith. A patient absolutely can breastfeed while taking Zuranolone if they choose to. And the general rule of thumb, my trainees know in all my women's mental health clinics, I make recommendations, you make decisions. We discuss this with the patient. This is what the recommendation say, but it's the patient has the power to decide what she chooses to do. So if there's a clinical need for Zuranolone and the developmental and health benefits of breastfeeding, permit, it really should be balanced, I think, through a shared decision making with the patient and considering so many different factors like continuing. Does the patient want to continue? Does the patient want to completely stop? They can. Do they want to discard the milk like a week postpartum? If they choose to do that, sure. But I think a discussion just needs to be had. What about OCD or unclear mania or psychosis? So the exclusionary criteria in this study, it excluded bipolar affective disorder, psychosis, and active substance use disorder. So I would certainly follow the evidence-based recommendations. So those were strict exclusions. Anyone with psychosis or psychotic symptoms has to be sent to the ER. We don't want to talk about Zuranolone. We just want to get them safe and ASAP. And if you're thinking about bipolar affective disorder and psychosis secondary to bipolar 1, and you're unclear, a diagnostic clarification, doing a mood disorder questionnaire, calling MCPAP for moms can help discern that. But that is not an indication to start Zuranolone. This is for unipolar depression with perinatal onset, third trimester and 4 weeks postpartum. And for OCD, I mean, I don't see a reason to not prescribe Zuranolone during OCD. I would think, so the studies did not mention OCD, but I would think that some of those patients did have OCD, and especially the postpartum phase, obsessive compulsive thoughts and features, they're so common. And I don't think it's a contraindication. I think it's certainly something that could be prescribed on that. So I would say if someone has, moderate to severe depression and OCD features, I think it's fine. OCD was not an exclusionary criteria, so I think clinically it would be okay to do. And I would just say if an SSRI needed to be added on for any reason, you probably want to stay away from the sedating ones, like Luvox for OCD can be really sedating. Sertraline can be sedating because that can add to the somnolence effect of Zuranolone. That's the only thing I would say. But yeah, the evidence says for unipolar major depression, OCD, sure, I think that's fine, but not for bipolar disorder, mania, psychosis, not for active substance use. Can you speak to the cost? Yes, $16,000 for a 2-week period. And I know that there was speculation it would be between $10,000 to $20,000. Brexanolone, I think, was like $30-something thousand. it may even be higher. I'm not remembering correctly right now. It's in one of the slides. So, it's oral, it's not IV, so the cost is going to be less. There's less logistics because Zuranolone was in the hospital. But I think the key thing is really that slide and following those steps so we can make sure we get the best coverage possible for our patients, and utilizing the supports we have, and asking representatives from Biogen or Sage or calling MCPAP for Moms to help get full coverage for our patients to really make sure who's eligible and getting into that. I know I'm 2 minutes over. Thank you, everyone. So sorry for the technical delays. It was great to talk about Zuranolone with you all today. Thanks so much for coming.